Hi everyone, thank you so much for tuning in. Today we're really happy to introduce our guest, Josh Rosenberg. So for a bit of context, Dr. Rosenberg joined Mount Sinai in 2012 as an associate professor, where he received his medical degree from the Albert Einstein College of Medicine, and he also completed his internship in general surgery and residency in
Okay.
otolaryngology.
Can you leave this on the podcast? Because this is the best part. Otolaryngology, and that's short for ear, nose, and throat, right? So that's a
Okay.
formal medical specialty name.
Okay, well, I'm very grateful to know how to say this word now. So you should quiz me at the end of the podcast to make sure I got it. But to continue, Dr. Rosenberg is an expert in facial plastic and reconstructive surgery and microvascular reconstruction. A lot of his clinical interests include facial rejuvenation, facial cosmetic surgery, facial reconstruction, facial paralysis and Bell's palsy, and facial gender affirmation surgery. In addition to maintaining his cosmetic and reconstructive practice, Dr. Rosenberg spearheads several ongoing projects, including novel techniques in facial plastic surgery and the utilization and development of telehealth models, especially for surgical and procedural specialties. By better understanding treatment outcomes for this debilitating and disfiguring condition, Dr. Rosenberg helps to tailor treatments for each individual patient's needs. So, just going into that, like you have such an amazing background, but it is also interesting that in college you did study political science and public policy before choosing medicine. And so we were all really curious what ultimately drew you towards clinical care, and has that influenced you at all and stayed with you throughout your medical career?
So in residency training, we have six core competencies, and those are the six things that you get evaluated based on: medical knowledge, patient care, practice-based learning and improvement, interpersonal communication skills, professionalism, and the sixth one is systems-based practice. And that sounds somewhat vague. And when I was a resident, those core competencies became official in like the late 90s, early 2000s by the ACGME, the board that handles all residency curriculum and education. And so that was just being integrated into my residency training. But systems-based practice, in a nutshell, is understanding how you, the clinician, interact in a much larger healthcare system or bureaucracy, if you want to describe it that way, and how the needs of your patient and the needs of your practice are part of a very large system where in order to do anything, or basically a variety of things, affect change or even just deliver care, it has to be within the context of all of that. And so that's always been really, really interesting to me. And it's interesting to me partially because I love showing up and saying, hey, this is what I'm planning on doing today, and it's all going to happen, and you've all been ready, and then find out that there's like 1,000 other stakeholders who have a variety of different ideas of what's going to happen that same day and how we navigate that. And so that's how I've continued kind of my interest in all the other parts of things I studied as an undergrad. Part of it also is just as I decided what I was going to do with the rest of my life after undergrad, I moved. Medicine just seemed like a very good fit for me in terms of both my interest, my skill set, and my interests really were a career that would both be engaging and also challenging from day one through whenever I decide to retire. And that's something medicine has definitely delivered on. It keeps you mentally active. I think that I'm probably younger than my age in some ways, simply because every day I go to work and I have to solve a lot of problems brand new, and deal with everyone from the very old to the very young, to my residents, through senior physicians, through my patients, and on and so forth.
No, that's amazing. I think that that really just speaks to how it's really valuable to have a diverse perspective and background to help you in the medical space. And so, kind of continuing on with that, how is your experience in medical school and residency different from what students are facing today? And in what ways did you feel like your path might have differed from your peers at the time?
So it's always hard to really identify what's different now from today. But there are some definite structural changes that have happened to medical education. So one, curriculums have changed. When I was in medical school, it was still the very classic curriculum, which was the first 2 years were preclinical, mostly classroom. We had some small group sessions on how to do an exam, how to take a history, and the different nuances of that. And the nuances of that are much harder than you think. Like, for instance, I still remember, maybe because, it's my relative level of maturity, but, when we talked about how to take a sexual history, that is actually, a very sensitive area, but it has a lot of information you need to glean from that, and you need to learn to ask that in a professional way. And if you've never thought about it, suddenly you're like, wait, I have to ask people about these questions in a way that's going to make them comfortable. And so those group sessions are very useful, but mostly we just spent the first 2 years sitting in a classroom, getting a lecture type format and getting tested on it. And then you took step 1 of the boards, and then you spent the last 2 years just on the hospital wards, really with very little classroom work. Nowadays, medical curriculums are much more integrated. So you really do start in the clinical side of things from day 1. And every school is a bit different than that, but it has changed quite a bit. There's also, among the students, a lot more CV building than I think there was when I was a medical student. So for instance, and we'll get into this later, the surgical specialties in particular tend to be very competitive to get into for residency positions. And when I was a medical student, I don't really remember all of us from day 1 being like, I want to be this kind of surgeon. Let me go do research at that department and build a 30 publication CV. Whereas when I look at the applicants who are applying now, I mean, it's really, really impressive. So they often start from day 1 of medical school saying, this is my goal, I'm going to build the CV, and they happen to be doing as many activities related to what they're interested in. But ultimately, and I think the biggest difference is kind of generational. And when there are some real generational differences between Gen X and the baby boomers. I would be Gen X, I'm not a baby boomer. But and then millennials and Gen Z below us. And those differences aren't bad. One of the key insights I really got from one of my colleagues when I first started. One of my colleagues named Marita Tang is our program director, and she's a real leader in residency education. And one of I think her key insight and the thing she took from early in her career was that you have to meet people where they are. And so, for instance, again, especially when I was a younger faculty member and a younger practicing physician, there were a lot of other faculty members who were quite a bit older. And whenever there were issues or, we had various things with the residents, there was oftentimes a lot of chit chat that turned into like, well, when I was a resident, back in my day, which is single-handedly the most reductive and least interesting way to critique a problem, and also the single best way to make sure the person you're critiquing isn't listening to a word you're saying. And so Dr. Tang, whenever you come to her with that kind of attitude, she immediately sits back calmly and says, well, explain to me what's really going on. A lot of the issues tend to be more interpersonal. Millennials and Gen Z all of our residents are incredibly high achieving, hardworking people. I mean, there's no way around that. The least hardworking among all of our trainees is still in the hardest working echelon of all people in this country. I have no doubt about that. But oftentimes that Gen Zs and millennials tend to be a little more transparent about the kind of mentee-mentee relationship, the school-student relationship. Basically, they're very clear about what they want out of it versus what you're providing for them. And that's not a bad thing, but you have to learn to meet people where they are. Whereas when I was maybe a younger resident, a faculty member would just tell me to do something that may have been no real value to me or them, and I would just maybe say, oh, well, that's life. Nowadays, I think you're going to get a little more probing and questioning, and that's probably, I actually think it's a better thing, because making people do busy work that we're never going to use is kind of useless anyway. But also, if you're just criticizing people for that attitude, you're not actually effectively training them or building good relationships with them or getting the best out of them. And our goal in medical residency and medical students in training is to build the best surgeons, the best doctors, and the people who are going to take the best care of patients.
No, that was amazingly well said, and I really do think it is important to have that ability to build up doctors in that way. But in some senses, there are also a lot of issues that people have relating to cost and actually getting access to medical school. And so we were wondering, how did you think about the financial reality of medical school, both while deciding to pursue it and while you were in training?
Cost is a real concern. And I probably didn't think about cost as much as the current student is for a number of reasons. And I went to medical school in the early 2000s, it wasn't that long ago, but it was fundamentally very different. The cost of medical education, I think, was about half. And if you look at the debt numbers, I think when I went to school, the average student was graduating with about $100,000 in debt, as opposed to around $200,000 to $300,000 a day. So that debt is doubled, tripled, or even more. The other thing, which is kind of a joke I make to our residents, and then I lord it over them a little bit. When I graduated, it was like a great economy and interest rates were super low. Whereas nowadays, people are consolidating their loans at much higher interest rates, and that's a real burden too. The other end of it is, and I didn't realize this, there was an article, I think it was in the New York Times from a couple of years ago, and I'll have to look it up someday. If I find it, I'll send you the link. And it was about both the debt burden of medical students, but it was also about the lifetime earning of physicians. And if you look at the numbers, even physicians in lower paying specialties still financially do very well compared to either your average American or even your average middle class American. So the debt is a real thing, but it's not bankrupting or necessarily bankrupting a large segment of doctors. At the same time, it definitely influences. It's like everything else in this country. Money starts to influence how other decisions are made, including what specialties are sought after, where people go to practice, why they practice certain areas. And there's a couple of interesting ways to look at this. One of them is it's a debt to earnings ratio. I think the debt burden ratio. So it would be like the educational debt at graduation plus your early career salary as an attending physician, not as a resident. That will equal your debt burden ratio. So very specialties with a high debt burden ratio, like all the primary care specialties, those people or the specialists in those fields are typically earning, let's say, $200,000 to $250,000 after they graduate a year, but then their debt is equal to that. Their debt is like $250,000. Whereas if you go into a surgical specialty like plastics, orthopedics, neurosurgery, ENT, your debt might be $200,000 to $250,000, but you're earning on average anywhere from $450,000 to $900,000 a year. So your debt burden ratio is so much lower that it makes those fields more attractive. And then there's that downstream effect where suddenly all these fields like ENT, dermatology are super competitive to get into. And do we really need that many of all of us? That's one. Two, also where people practice. So there are a lot of people who are interested in practicing in very diverse geographic locations. But for instance, let's say we need more doctors in rural America. Well, a lot of rural communities have a poor payer mix. They don't have as much money to spend on healthcare. And so doctors don't go and practice there, even though they might be from there and they're interested in practicing there. And, it's hard to find a primary care doctor in any setting these days, but especially in urban poorer centers or rural areas. But then finding a specialist becomes even harder because no one goes and practices there.
Absolutely, and I see your point as to how this is making a lot of different specialties more and more competitive, particularly when it comes to surgicals. Branching off from that point, I wanted to ask you particularly, what inspired you to choose plastic surgery as your route of medicine? How did you navigate the residency process? And how did you explore your options as to what cases you wanted to specialize the most in?
So there's obviously a lot to that. And I was listening to, I think, your podcast from the last podcast you had with a lovely student who was talking about how from when she was 7 years old, she wanted to be a doctor. And I don't have that story. I was never, as a teenager, even as a college student, I thought, oh, these are interesting things, but I wasn't thinking I want to do X, Y, or Z specifically. So when I was in medical school, I went to medical school, I was obeying my parents. And when I was I remember this epiphany really clearly, or this moment. I was studying for step 1 of the boards, which is a really important test, especially back then it was graded. It's now pass fail, and those numbers were very determinative of like how competitive a specialty you could apply to. And I was thinking, I was like, wait, I have to figure out like what I want to do. Like, I'm not just going to quote, be a doctor, like what kind of doctor am I going to be? And I had never really thought about it before. And that's when I started to sit down and think, all right, what am I really interested in? When I moved to my clinical years, I remember the first time I was in an operating room clearly. When you do your clinical years, as at the third year student, you have a set number of specific rotations, typically, and it can vary by school, but it's always some combination of OBGYN, general surgery, internal medicine, pediatrics, neurology. I'm leaving something out, but I'm forgetting it. So my first rotation was on OBGYN. And I remember I went in my first night on call, and when your first night on call on these things, when you're not used to being up for 24 hours plus, can be really exhausting. But I remember I went in for this cesarean section in the middle of the night, and just the whole hum and beat of an operating room I just was like, this is awesome. Like, it's really exciting, it's enticing. And I remember thinking, I think I really like this. Then I went on and did the rest of my rotations, including obviously general surgery, and really enjoyed being in the operating room space, which is one part of it, but it's not the whole thing. Because surgery isn't just being in an operating room, it's a whole set of how you approach patients, of decision making, of the kind of care you're delivering. And I really enjoyed the problem solving, both the intellectual problem solving with the hands-on component to it. I don't want to emphasize the hands-on component too much, because ultimately the hands-on component is something that most people can learn. It's very, that's very accessible, but it's the decision-making both before surgery, during surgery, and after that is really the most challenging part of surgery, and the part that I found both attractive when married with the rest of it. In terms of specialty selection, how I ended up where I am is probably a lot of happy accidents and other good things. So I trained in otolaryngology first, which is ear, nose, and throat, which is all head and neck surgery. So that's everything from taking out tonsils to advanced head and neck cancer and advanced head and neck reconstruction. And then after residency, I did fellowship, which was specifically just in advanced facial plastic surgery. So it was in cosmetic surgery of the face, along with advanced head and neck reconstruction, like microvascular surgery, and those kind of things. And then went on to build my career after that. So the exact decisions on how I ended up in those places, I can't tell you I'm totally sure on even how I chose ENT, but I knew that I liked the people in the field. I enjoyed my time working with the people I met, so I thought this is a good fit. The other thing is surgical specialties notoriously have a lot of tough personalities. Now, that touches back to our prior answer. We were talking about how medical school has changed. One of the things that's really changed is there is, I would say, among both medical school leadership, medical school mentors, and even residency leadership, basically hospitals in general, like a real growing low tolerance policy for the kind of behavior surgeons used to typically engage in. And so like when I was still in training, I'd see these older surgeons throwing things at people, yelling at people, demeaning them. Like, that's not tolerated anymore. But I remember when I was a medical student, general surgery in particular could still be really tough that way. Whereas in otolaryngology, it was full of these really smart people, all this really cool technology, and the people were actually kind of nice too. So I was like, oh, this seems like a nice fit. It fits all of the things I like. When I was an ENT resident, I really enjoyed all of the soft tissue work. So all of the reconstructive surgery, all of the sewing, all of the just the basic mechanics of it. And I also enjoyed the patients. I enjoyed doing a rhinoplasty, seeing that patient walk out feeling much better about themselves and being happier about things. I enjoyed the challenge of head and neck cancer reconstruction. And when you think about all cancer care in this country, even from the 1980s, the 1990s today, our cancer cure rates, our 5-year survivals, they get better all the time. But for things like head and neck cancer, we are really good at treating it. But one of the problems is it's very morbid. It often leaves patients really disabled and disfigured in deeply socially meaningful ways. And so we can cure your cancer, but if we leave you unable to speak, unable to eat, you now can't work. You can't socialize with your family. Try going to Thanksgiving dinner and having your feeding tube bag there, right? It's just not the same thing. And so the challenge of head and neck reconstructive surgery is to take patients where we've cured their disease and now get them back to fully functioning people who can go out and get the most out of their lives. And that's like an incredible challenge and something that I found really, really attractive. So when I was thinking about kind of where I want to go in my career. The final part is, how did I end up starting in 2012 to where I am today, where I'm doing a lot of very specific things? And a lot of that is just, it's happenstance. So when I started as a junior faculty member, the chairman of our department, who's a great mentor of mine, sat down with me and said, what are you thinking about doing. And he actually said to me, have you thought about facial nerve paralysis? Because it's a big issue for patients. It's a big issue for patients in the head neck reconstructive space. It's a big issue with patients having lateral skull-based surgery related to hearing or neurosurgical problems. And it's something that's relatively undertreated. And I actually hadn't thought that much about it. But it's something I had good fundamental skills in and said, this is a great area to take my career. When it came to gender affirming care, when I was training, the amount of people doing gender affirming care in this country was very small. It really wasn't a big on people's radars, and it was deeply inaccessible. And that changed a lot over the last decade and a half. Mount Sinai started a center in the late, maybe sometime 2016 to 17, specifically to help. It's called the Center for Transgender Medicine and Surgery. So it's to help kind of forward transgender care and also provide transgender care and gender affirming care. And there was a huge volume of patients, and they needed people to do, let's say, facial surgery, and they approached me about it. And although I hadn't specifically trained in it, it involves all of the same skills we've already had. So then, I started doing some of those surgeries with some of my colleagues who had some fluency in it, and we really grew out of that, and it became a big part of my practice. And so for you and most likely your main audience, which is going to be students who are going to medicine, one of the things I emphasize to students, especially to our residents, but also to students, is you want to get the best training possible in everything you do, because you never know where your career is going to take you. And what's going to happen is if you have a great skill set, you're able to match that to almost any situation you'll be in. And that's really, it sounds like trite advice, but I can give, I've given you specific examples, and I can talk till I'm blue in the face about how that has been the reality of my career in every way.
So yeah, for me, it's particularly interesting how you were mentioning this breadth of experience you've had, within the surgical field overall, and specifically your advice as to you should get the best training possible and be prepared for any type of problem that may come your way in the best way possible. How do you believe future trainees should approach this breadth versus depth? Not problem, but more so tension that I feel would arise when you're getting educated as to perform these very specific procedures.
Kind of how to prepare for the future, I think, is maybe the best way to say that, especially in the field where AIs become reality, robots are becoming a reality. And it's the advice I even give to my 11-year-old, which is we're always in the yes and space, the improv space, right? Everything's a yes and. So, and I'll go to some of my mentors. The chairman of our department, the one who gave me that great advice on facial paralysis, he was one of the pioneers in head neck robotic surgery. So for some of your audience who might not know that, there's a whole new generation of robots that are probably coming out on the market into the field over the next decade or so. But for about 20 years now, we've had this one main robotic surgical system. It's called the Da Vinci system. And its biggest uses are in urology and prostate surgery, but it's also revolutionized parts of head and neck cancer surgery. So head and neck cancer occupies all these different areas in the throat, the nose, down through the voice box. And a lot of it happens in the oropharynx. That's the area behind your mouth where your tonsils sit, for instance. And it used to be, that's a very hard area to access surgically. So it used to be that you either got radiation and chemotherapy for those cancers, which is very debilitating, does significant long-term damage that can make it hard to eat, swallow, and speak, or you had, it's not always or, and you also had surgery that usually involved splitting the jaw. So, you make an incision along the lip, open the face, you'd split the jaw in half, move the jaw out of the way, get to the back, take all the cancer out, reconstruct the area, avoid hitting the carotid arteries and jugular veins and all these important nerves. And then you'd put it all back together again. And then that patient, while healing, would then get radiation and chemotherapy. And you could imagine how debilitating that was. The robotic system now allows most of that surgery to happen through the mouth without splitting the jaw. And because of other advances in cancer understanding, we're also doing less radiation therapy and less chemotherapy for those cancers, partially because we understand the cancer biology better, and also partially because the surgical access has allowed us to clear those surgeries more effectively, clear those cancers more effectively with surgery. And so one of the things, though, is that when that robot first came out, a lot of people are like, what's the point? I can do this surgery the way I know how. But my mentor was like, no, this is a great idea. And he was one of the early pioneers in doing that kind of robotic surgery. So there's always new things coming out. It's going to happen from today through whenever, an asteroid hits Earth or whatever happens a billion years from now. And the more you're willing to engage with it, the better off you're going to be. The other great example would be telehealth. And I'll tell you, I've been on both sides of this. So in 2019, someone from our health system came to me and said, hey, do you want to do telehealth? And I said, no, that seems ridiculous. I have a perfectly busy practice. Why would I waste my time on that? And then suddenly during COVID, I was like, this telehealth thing is the only way I can see patients. And I quickly realized this was a great technology and has the capacity to maybe really change how we deliver healthcare in a lot of circumstances. And it was really eye-opening. And I really, really realized that, don't say no to anything, right? Just because you think you have something good happening doesn't mean it can't be better. And that's like the fundamental part of patient care too, right? Just because we have some things that maybe work kind of doesn't mean we've cured, any specific problem in particular. And we should always be looking for any new idea, no matter how far out it sounds. Now, obviously, use your judgment, right? But even when industry comes in with things, I don't immediately blow it off as, they just want to make money off me. They have solutions that might be able to help us get better answers for our patients, and you need to listen to everyone.
Just on that note of learning and speaking with a lot of different people and listening to everyone, you do have a lot of patients that would have a lot of different needs and goals. And so in that sense, how does your mindset or definition of success change depending on the type of facial surgery that you're performing?
You're right. I treat a number of things that are somewhat different. And so on any given day, I'll be seeing, let's say, a teenager, a young adult who might be interested in a rhinoplasty, and then the next minute be seeing someone with a facial paralysis or another thing like that. And so they all have, fundamentally, all patients want is to get the best outcome possible. But I think our job as their physician or their surgeon to explain to them what those outcomes are. And that's kind of the approach I take. So to give you an idea, again, when I'm seeing someone who wants a rhinoplasty, I really do, they are already in good health. They're basically perfect already. And the question is, can we make them a little, either make their nose look a little better and or breathe a little better with surgery? But it's also my job to explain to them that surgery is not the same thing as, let's say, contracting. That when I'm building a house or doing anything that's kind of architecture building related, 1 + 1 always equals 2. Whereas in surgery, especially in healing from surgery, 1 + 1 can equal a variety of different things. So because they're already healthy and already great the way they are, it's really important as part of that consultation and consent process that I clearly explain to them the risks of these things, what the outcomes are, what their expectations really should be, so that when they decide to go forward, they're doing this with as much information as possible. It's what we call shared decision making is the kind of modern term for patient autonomy. And shared decision making takes many forms, which you're touching on. So let's say you need a heart transplant. The team is going to talk to you about the risks of surgery and what could go wrong. But ultimately, most people are going to decide to have that heart transplant because they want to live. Whereas for a lot of what I do, especially for anything that's cosmetic, but even the things that aren't cosmetic, it's really quality of life oriented. So for instance, you don't need a rhinoplasty to live. And oftentimes even our facial paralysis patients don't need facial paralysis surgery to live, but we want them to get the most out of their lives. So it's our job to both explain to them what we can do, but also make sure they're really well informed about what we can't do. The other end of that is especially when it comes to things like facial paralysis, is we cannot currently cure facial paralysis. And just for some background info, because it's a little more of a less common diagnosis, maybe some of you know people have had Bell's palsy and things like that, but you'll see people who can't move usually one half of their face, which on its doesn't seem immediately like a big deal, but you have to remember a couple things. Emotive facial expression is like one of the key parts of human engagement. So when you can no longer do that effectively, it's a huge social burden. And so there's reams of data for patients who have chronic facial paralysis that they have lower rates of social engagement. They have much higher rates of depression, anxiety, much lower rates of professional success. And at a very visceral level, this is like the person who doesn't go to family dinner because their grandkids are scared of them. They look sad all the time. Patients ask, why are you so sad? And they're like, I'm perfectly happy. I'm frowning because I can't move part of my face. And so for those patients, the first thing I tell them is, I cannot cure what you have, but I can do these things to make it better. And that's a really, really important thing to tell people, because I'm setting up front what I can really do for them. It's very easy to be like, oh, yeah, it's going to be great. But if I'm not really relaying to them what I know the outcome is, I'm not really doing them a service, because ultimately their autonomy is to decide whether to go further with their care based on what they're going to get out of it. And my job is to really walk them through all that in the most realistic way possible.
I think that's a wonderful transition into our next question to you, which is about the conversation of cosmetic surgery and culture that's going on right now. Typically, cosmetics are often criticized as reinforcing insecurities or suggesting that patients need to, quote unquote, fix things about themselves. How do you respond to that critique, and how do you ethically navigate patient autonomy, like you just said, and then existing social pressures in your work?
So, I take that critique very seriously. There's always these elements of culture of social pressure. But at the same time, most of our patients, they're not really asking to be fixed. They're really asking for their appearance to reflect how they feel on the inside. And whether that's patients seeking reconstructive surgery, just want to be treated as healthy, vital members of their community. Remember, when you can't speak effectively, or you can't smile effectively, people treat you like you're sick when you're otherwise perfectly healthy, and they just offer you less things. When it comes to things like gender affirming care, I think that's more obvious, right? Being treated as a gender that you might not identify with could be incredibly, incredibly difficult. And so it's not really that we're going to fix them by somehow making them look better or more perfect, but it's that we're going to help their outside appearance align with how they feel on the inside. So when it comes to specifically cosmetic surgery, there's really two parts of that. One, there's facial aging surgery, things like facelifts and eye lifts. Remember, people are living younger, healthier lives well into their older age, more so than a generation, 2 generations ago. So people in their 60s and 70s are as active and healthy as people in their 20s and 30s. Their knees might hurt a little more. I can tell you that from experience. I'm not 60 yet, but overall, everyone's still busy doing things. So you don't want to be treated like, oh, you can't, play a great game of tennis because you just have you don't look as young as you feel. And so that drives a lot of it. The other part of it is, and this is, I think, a harder thing to put an exact idea on, but social media and what's social media driven. Social media has been a huge driver for plastic surgery, and there's a growing body of data to support that. And the question is that a good thing or a bad thing? I think it really depends on where we take it. So one of the things I advise all of my patients, because our patients now are skewing younger and younger for things like facelifts, eye lifts, in ways that a generation ago, we just didn't see very many 30-year-olds for that kind of stuff. Whereas now people are walking the door and they want those things. They've seen it on social media. And so it's really important for us to educate patients what that means. For some people, those choices are very reasonable and they are good ideas. But for other people, it's not going to really get them the improvement they're looking for. They still look very youthful, so you're not going to suddenly change that. Number two is social media still is very driven by people showing off specific outcomes in very specific contexts. So the lighting is good. They're showing off their best results. If it's a surgeon, they're only showing their best results. You have to explain to patients the difference between that kind of maybe soft marketing a little bit of their practices or their skill set versus what reality is. Finally, there's also I'm trying to think of how to phrase this. There's also just the aspect of social media where patients are coming and asking for things that they don't need at all, right? It's just not even relevant. They just saw it. And that's where just educating patients about what you really can do with medicine and surgery versus what is and not a real thing becomes really, really important.
It's wonderful that you really emphasize that educational aspect, because I think that's huge. And I think the wonderful thing about social media is access to information. But like you said, there's definitely this practice of a highlight reel. And I think part of the plastic surgery impact is, I feel like celebrities used to hide a lot of their cosmetic work, and now I think it's very wonderful to be transparent. But I think as a result, it's created this narrative and shown this pattern that if you want to look like this, if you want to replicate this, this is the only pathway. And then you have young girls, young boys, everyone just internalizing this information without necessarily knowing all the costs, quite literally, to your body. My follow-up to that, like you said, mentioning you're one of very few surgeons in the US who's able to do gender affirming care, but then also do so well. Everyone follow him on Face by JRo on Instagram. I mean, some incredible nose jobs are out there. How do you navigate existing societal conversations about that work?
So one thing is, if you ever follow my social media, I actually delved into politics this week, kind of with a lot of trepidation. I really try to avoid it. One thing I feel very strongly about is I am not a political activist. I'm not a policymaker in that space. I do have expertise in the surgery and the science of gender affirming care, but that's very different, or it intersects with, but it's not the same thing as policy discussions. So it's not really my place to do that. So I try to avoid those discussions for the most part, in the sense that I'm not here to advocate for any particular policies. But I do want people to understand that all of our patients are human beings, and they are individual human beings. And there's obviously policy choices. There's a lot of things that happen on a much more global scale. But as a physician, my job is to take care of the individual in front of me. It's not to take care of them and their politics, right? That's very ancillary. One of the things that I would also encourage people to consider, which I think is an interesting fact, is especially we all do this as human beings. We tend to think of people as kind of monolithic groups, right? Like, this patient is this, so they're going to believe this. And especially among my gender affirming patients, I can tell you that the political diversity among their views is eye-popping. And you should not assume just because people fit into a specific role that they have a specific set of politics or preferences. It's really, really impressive. And the more you get to know people, it's really fun. And then this is, I think, advice that's also great for pre-med students, for anyone in general, but also pre-med students or people who think going to medicine. You're going to have moments in your career where you have cured someone, saved their life, whatever. And they're going to tell you about it, and it's going to be like it's going to really touch your heart. But day to day, hour to hour, that's not happening every 3 minutes. Most of your day is just in conversation with people about what they want, the work you do, and you have to really just learn to enjoy them as people. Chat with them about what they like, joke around a little bit. And if you do that, your day goes by very quickly. If you're just trying to slog through getting all the facts and moving on, that becomes really, really dull and a lot less interesting. So part of the joy of medicine for me has been not just waiting for the great moments, but also learning to enjoy all the little moments. And that's learning about your patients as individuals and caring about them as individuals.
Thank you. That was so well worded. I adored that answer.
I truly believe the way you approach seeing your patients as individuals and meeting them at the moment they're at is truly admirable and something the physician profession should definitely embody. However, I'm very curious about this aspect. A quick look over your Google Scholar, it is very clear you do a lot of research that is very specific to the work you do. So this is coming from me as someone who would like to perhaps be a physician scientist in the future. How do the patients you care for shape the research questions you ask and how you tackle them? And how does this research in turn shape the way you practice clinically?
My research is really outcomes driven. I don't run a basic science lab or anything like that. So it's really, my research questions are driven by the kind of patients I see. And the main question is what I'm doing working, and can I do it better? There's very few things that we've cured it, it's perfect, we can move on, right? That doesn't really exist in medicine. So specific to me, one of the areas that is one of the hardest things I treat, and the area that's driven a lot of our research interest, is facial paralysis. And partially because, let's say, and a common type scenario would be that you have there's certain kinds of tumors, certain kinds of neurosurgical brain tumors, something called an acoustic neuroma. And that's a tumor that sits on the hearing nerve, and then it sometimes needs to be removed. And the facial nerve is intimately related with the other nerve, and patients get facial paralysis from that. And sometimes they don't recover. A very, very well-known case of that would be the actor Mark Ruffalo, who had acoustic neuroma surgery in the year 2000. And if you watch him in some movies, you'll see, I think it's the left side of his face is just a little tight and doesn't move as well as the other side of his face. And for patients who get no movement back, when we do a variety of what we call nerve transfers and nerve grafting, where we reroute the nerves other places, and then we also transplant muscles from other parts of the body to help rebuild the smile, and we typically get about half the function back. We have a grading scale for facial movement called the House-Brackman scale, and 1 being perfect, 6 being no movement, and the average outcome is about a 3. So we're getting about half the function back. It's great. We have tons of data to show that patients who get facial reanimation have much better quality of life outcomes than patients who don't get any reanimation. But their quality of life is still not the same compared to a normal cohort of patients. So we have not cured facial paralysis. There's a number of new technologies and devices on the market. One of them is a processed cadaveric nerve graft. So typically, if you want to do nerve grafting, we have to go harvest a nerve from another part of your body, and it's fine. It's not hard to do, and typically the nerves we're taking don't lead to disability anywhere else, or not significant disability, but it's also not always available or accessible. So now we have this processed cadaveric nerve allograft. That's from a cadaver, someone who donated their body after they passed, and that's been processed. And now we're starting to use that increasingly for these different kind of motor nerve repairs. But the data, it's still relatively new. The data is not definitive, so that's one area of our interest is what are the appropriate case uses for this? Can it be used for all cases? There's also various devices to help make the connections between nerves when you sew them together under the microscope better. But the data is unclear about that. And one of the reasons why I'm really interested in it is it not only can help my own patients, but things like nerve repair are technically challenging and typically only happen at like larger centers because it's generally better done by someone who does a lot of it compared to someone who does very little of it. But a lot of these devices are meant to make it easier. And remember, the goal of healthcare in America is not for you to find the master surgeon at the big city hospital and travel hours to get there. And if you're lucky enough, you get to have surgery with them. It's for you to go to any doctors or hospital in any community you're in and get the same quality of care. And so all of these new technologies and devices may have the potential, I don't want to say they definitely do because it'll be variable as we learn more about all of these things, but may have the potential to make healthcare more accessible to people across the country. And in one of my facial paralysis talks that I give to audiences or whatever, I actually have a picture from a New York Times article, and it was about some crime thing that had happened, and they had the mug shots of all the people. But one of the people, the minute I saw the article, I just saw this person with a facial paralysis, and that's what I had to go read about. And when I read that person's biography, it turns out they'd grown up in a rural area, they had been in a car accident, they had a fracture to their skull that paralyzed their face, which is a treatable problem. But according to when they were growing up, they said, no one could treat that around here. And those are the things we want to change. So that's a lot of my research questions are driven about how do we get good outcomes, then also how do we make those outcomes reliable so that anyone could do them. It doesn't have to be just the one person who happens to know about this in Boston or New York.
That is truly amazing. I really like how the way you're planting research questions is always geared towards impact and how to make all these advances more accessible and equitable across the board. I believe this naturally lends itself to the discussion of telehealth. I know you don't like this word, but given your specialty is pretty hands-on, I wanted to ask, how do you integrate telehealth thoughtfully while maintaining quality, trust, and the rigor that must be incorporated into care to begin with?
It's not easy. And I remember when we first started integrating telehealth in the practice. So during COVID, it was kind of a necessity. If you wanted to follow up with patients, you had to see them via video. Even when we got back into the office, we couldn't keep a full complement of people on the schedule. So we'd have to shift a certain amount of people to telehealth and just it was, I guess, better than nothing. But as the world got back to normal, we started thinking about how we could use telehealth more effectively. I remember being in a meeting with a bunch of my colleagues, and there are various levels of either enthusiasm or skepticism for telehealth. And one person had said, well, can we just put a disclaimer that says the care you may be getting via telehealth is not as good as the care you get in person? And at least I was like, listen, you can't just tell people you're giving them substandard care, because then you shouldn't be doing it. So if we're going to do telehealth, we have to agree that it's good care. Otherwise, don't do it. And so for my practice, what telehealth has meant is a couple of key things. One, I use it for new patient consults all the time. The understanding is I'm not seeing you in person. So there are things that I probably do need to examine you for. But if you want to meet me, learn about what your surgical options are, hear about what things I can offer you, that is a very valuable tool without having to take time off of work, come sit in the office. The other thing is telehealth is great for follow-up. There are some times when I do need to see patients to, look at the surgical sites or look at what we've done, but oftentimes a lot of visits are just a check-in to answer questions, to say, I'm concerned about X, Y, or Z, what are we expecting? And telehealth is great for that. The real limits on telehealth are still physical exam, which could be changing and I think will change over time, and I can get into that. There's also a lot of regulatory issues with telehealth. So, and I'm not sure where it is right now, but Medicare wasn't covering certain kinds of telehealth for a little while. Now they might be back. I'm not totally clear. There's also state licensing things. So you can't provide telehealth in states you're not licensed in, which does limit the impact of its utility across large geographic areas, especially when you live in a place like New York, where you're seeing patients from, at the bare minimum, New Jersey, New York, Connecticut, Pennsylvania. When it comes to physical exams, so early on, I worked with and did a little research with a company that built basically a home exam device. And it was it was an awesome device. I think it's still out there, but I don't know how much penetration it's gotten. But it basically had an otoscope to look in the ear, oral cavity exam, temperature and all these other things. And what it did was it paired with the iPhone, and then it had the exam devices. But most of the time when you're doing telehealth and ask a patient to show you something, they show you like the ceiling, right? They don't really know how to examine themselves. So what this device had was a augmented reality overlay. So you'd put it in your ear with looking at your iPhone, and it would be like a target. And when you got it in the right position with the right view, it would flash green. So you knew you were showing the doctor the right thing. It was expensive though. I think it costs about $500 for the device. There's some subscription fee, but increasingly, and you're seeing it now with like the Apple Watches, the different fitness devices, there's more data we can collect from people remotely. And I'm hope maybe, some of you are in biomedical engineering, maybe you'll figure this out. It might not be your area of interest, but hopefully there are even add-ons or parts of the phones and other devices we have that can help us examine various parts of the body, like the nose, the mouth, the ear, other sensitive parts of the body, and get real information to your practicing physician so you can have a very robust visit without ever coming to the office. Eye exams, for instance.
The funny thing about life is that it often makes sense in hindsight. Looking back, what do you wish you had understood earlier about medicine or about yourself as you look back on the path that led you to where you are today?
So a couple things I wish I had known earlier. And I hope this doesn't sound too cynical, but it's definitely helped me a lot more later in my career is, one, we talked earlier about systems-based practice. So again, when I was a resident, those core competencies were a little newer. I don't remember anyone ever talking about systems-based practice. I don't ever remember even hearing the term. Maybe I wasn't paying attention. It could be all my mentors right now were like, I told them about that 1,000 times. But once I understood it, I understood how not to bang your head against the wall. When you're in the hospital, you might say, oh, I want this new device or this new thing to help me care for patients better. But A, it costs money. The hospital cannot just spend money, on everything that everyone ever dreamed up. And B, even ordering something new is a long process. It just doesn't happen. It's not like you just get on Amazon in most cases and suddenly it shows up. There's all kinds of regulatory stuff and things like that. So once I began to understand how to move the needle, how to move the needle on affecting change through systems-based practice, it made a huge difference for my level of joy I got out of practice. Because I'm sure you've all experienced so far, but when you move into adulthood, there's a lot of friction in life, right? Life is not seamless. And the more you learn, and healthcare is full of friction. It's still a great job, but it's full of friction. And I think anyone who's ever been a patient has experienced experienced a lot of it. But we also feel it on the provider end too. And the minute you start to learn how to navigate that friction better, you end up being much happier. It doesn't make it go away, but at least doesn't seem so impossible anymore. And in terms of how to navigate that friction, listen to anyone and everyone you ever meet about it. The best advice I still get from it, and this is going to sound so corny, honestly, it's from my mom, who's worked in healthcare policy and government her entire career. And she had worked for many years, like for about maybe 20 or 30 years for New York State. She was a deputy commissioner of health when she retired from the state. And someone was giving a little speech about her and said, "I've never met anyone who can navigate bureaucracy as well as Linda Rosenberg." And from that day on, every time I run into bureaucracy, which is pretty much a daily experience that I can't totally figure out how to navigate, I won't call my mom every day about it, but I will call and say, "Hey, how do you navigate these things?" And so you're going to find your mentors in all of these different places that might not be directly related to your field, and always reach out about that because you can always use help with it. The other part of it, and this is where I hopefully won't sound too cynical, is I think if you understand medicine in the United States, it's about care to patients, but it's also designed as a set of business opportunities. And money is very determinative in medicine. That's not, there's a lot of, I don't want to get into the negatives and positives about that. That's a different set of things. But at the same time, if you understand it, it contextualizes why things are happening in a way that makes it more understandable. And it also helps you understand how to push the needle in the direction you want to go. Because you can come up with a great idea, but if it's going to cost a lot of money and not make any money, it's going to be very hard for that idea to translate. And so at least if you begin to understand that, you can understand maybe how to move that idea to reality.
Before I hop into our next question, what is Linda's best tip for navigating bureaucracy? Because I personally am someone that's super not patient with that, and I would like to get better.
I think really it's a personality thing. If you're engaging, if you respect the people you're speaking to and treat them with respect, and if you are nice to people, it's a lot of relationship building more than anything else. And I found that relationship building, and early on in my career, especially like in the operating room, I was not always a great relationship builder, and I wouldn't get what I wanted. And I remember, when you work, I'm sure you guys get like these Duke broadcast announcements all the time, or various emails about things going on, which most of us just delete. We had been in a faculty meeting, and there was one faculty member who was super angry about it. I don't even remember what it was, but he was notably angry the entire meeting. And later the day, one of my other colleagues, as a joke, sent me this broadcast announcement about this wellness and meditation course that Mount Sinai was offering, and was like, "Oh, we should tell this person to do that." I was like, "I'm going to take it." And I took it, and it was super fun. It was like this meditation course. It was all these people, all these practicing physicians who really did feel like overwhelmed by kind of like the stresses and burdens of just care delivery in these super complex systems. And I found it super helpful. From that day forward, I both learned the value of meditation, which I had never been that into, and also it helped focus me on the power of relationship building as part of navigating these systems. And ultimately, these systems are meant to be that relationships, they're designed so that relationships aren't the determinative factor, but we're all human beings, they still are. So that's the best advice, is you treat people with respect, you listen to them, and then you deal with them in an honest way, and you will get better outcomes, period.
Wow, you just dropped so many incredible nuggets of wisdom for our viewers. I'm going to ask you to pull another one out. What is one piece of advice you would offer today's pre-medical students who are still deciding whether or not to pursue medicine?
So it's a great field. I can't say enough about what it's given me in my life. And it's a long road, but the years are going to go by anyway. You are going to end up being 30, 35 and beyond. You might as well be doing what you like. And remember a couple things. It seems overwhelming, and it is. But at the same time, even during medical school and residency, you can have a life. So when you're a medical student, you think, God, I'm so busy. Just wait until you're a resident. I remember when you're a medical student, I don't know if they still even have pagers anymore. Like, I think we all use our phones. I know I use my phone with the residents. I've never paged them before, but or I haven't paged them in years. But I remember when I was a medical student, they'd give you this little pager, And it would never go off. And I think, oh, I can't wait till one day when this is actually, when people really need me. And then my first day internship, I was on call for the entire service. That's a big general surgery service. And that pager does not stop going off. I remember sometime around 3 in the morning being like, wait, is this forever? Like, is this thing just going to beep forever? And so it's very overwhelming, but at the same time, you can have a life during all of it. I was married during residency. I had kids during residency. I might not have seen as much of them, but hopefully they won't hold that too much against me with their therapist later in life. But you can have all of that, and you just have to be realistic. If you think you're going to have it all, like you're going to have this great, fascinating career, but also have all the free time in the world, no job works that way. That's entirely unrealistic. But if you feel like, hey, this is something that I feel very passionate about and that I'm really good at, and I like working with people, I like problem solving, you're going to really enjoy it. The other advice I'd give is the science component of it, especially if you're not, a lot of doctors love science, but a lot of doctors also are not like, we're never going to become real, PhD scientists. They're not as engaged with like the science work as, let's say, people who go to careers being chemists and biologists. And so when you're a pre-med, it can seem kind of just such a drag, right? Trying to get a great grade in your organic chemistry test. No one's excited about that. That's not what your career is going to be like. Honestly, if you ask me about even biochemistry stuff from medical school, some of it I'd have to be like, let me look that up. I'm not sure I can totally remember it now. Like, you really do get to enjoy just the problem solve, the kind of patients you work with, the pathology you work with, and the problem solving you work with. And that becomes a bigger part of your career. So don't let the pre-med stuff get you down. It's a drag, but you'll get through it, and it's a great career.
So to follow up from that beautiful response you just gave regarding pre-med student advice, from your perspective, what do you think should change to make healthcare more equitable, particularly for patients with complex or marginalized needs?
So, it's a tough question, and it's a tough question because there's probably no great answer to it, but on a global level, not a specific policy level, I'm not sure we need to spend more on healthcare, but we definitely need to spend it better, in the sense that we spend a lot of money, but it is all over the map, and the incentives are not usually well aligned. And let me give you a couple of, I think, very specific examples. The best example I can think of is cochlear implants versus spine surgery. For anyone in your audience or for you who don't know what a cochlear implant is, the cochlea is the hearing organ, and a cochlear implant is a device if you're deaf, we implant, if you can't hear, we implant that in the hearing organ, and it cures deafness. When prelingual children, especially before 12 months old, who are born congenitively deaf, get cochlear implants, they have the same language outcomes, the same educational outcomes, and the same lifetime, earning outcomes as patients who are born with normal hearing. So we've effectively cured deafness, right? That's like one of the landmark achievements of modern medicine. We should be celebrating that. Well, cochlear implants are expensive and typically either break even or lose money for most hospitals, right? For some reason, we are not incentivizing. We're doing it, but we're not paying anyone as much as we should for really one of the landmark achievements of modern medicine. Spine surgery, on the other hand, is a huge driver of revenue in healthcare. It's highly reimbursed. It drives, it helps subsidize care for a lot of other things that go on at hospitals. Hospitals have busy spine programs. Now, some of the outcomes from spine surgery are excellent, but there's also, when you look at spine surgery for chronic back pain, the outcomes are they're not great, or they're maybe mediocre or uneven. I don't want to impugn a whole field of surgeons who are going to come after me. So when we look at those two examples, we've basically cured one of the 5 sensory losses, and we're not incentivizing that or rewarding our ability to do that. Then we have this other set of surgeries that we don't have proven outcomes on, and we're reimbursing them super heavily. Now, they should all be paid reasonably. To me, that example really does show kind of how skewed some of the cost incentives are. So if we want to get healthcare to behave more rationally, if we're going to provide healthcare in a capital-based environment where the money has to flow for it to happen, then we have to at least make it rational and reasonable. Now, the harder part that's an easy thing to say. The harder part is making it rational and reasonable. And the best advice I ever got in healthcare reform. This was years ago. I was reading something about it, and the description that this person set up with was, picture you have to make a chocolate cake, but you have 7,000 ingredients and 300 other chefs you have to agree on to make those ingredients. And now make your chocolate cake. And that's a little bit of what healthcare is like. There's so many stakeholders. To really effectively change policy is going to be challenging, but it starts with really looking at how we spend the money and how we spend it in a rational way that incentivizes the best parts of care. And there are good things happening about that. When you look at every effort of healthcare reform, whether it's Democratic or Republican driven, they all mention primary care as one of the things that has to be changed, how we reimburse primary care and how we incentivize it. So everyone seems to be on the right track. It's just trying to get even some basic political consensus is quite challenging.
On that idea of kind of getting everyone on the right track and kind of thinking of the future of medicine, when you do think of the next generation of physicians, what stands out to you the most on how we can make those impacts?
You know what? I'm gonna make it really simple. The talent I see among our medical students, the questions they're asking, and they're savvy about the world. So one of the downsides of modern living is social media and the information environment, because it's overwhelming and there's you can waste a lot of time on it. I've wasted a lot of time on it. At the same time, the amount of insight and access, information it provides, each of you is more knowledgeable and more savvy about the entire healthcare environment, our political system, the world at large, than I think any of us were at your age, when our main access was newspapers and like the nightly news. And they all did a great job, but it just wasn't the same. And even now, I also, you can reach out to anyone you want via LinkedIn and say, hey, I'm an interested student. Would you have time to ask a question? Now, many people will ignore you, but some people will answer, and you'll get information that was just never accessible before, because you couldn't look up the CEO of HIMSS in the white pages or the yellow pages. Again, if anyone remembers that.
Before we close, we want to play a little game. So for context, earlier this semester, actually last semester, once our incubators finish their program, working with specific health projects in the area, we have a little showcase for them. And something that we created to just help build community is our own card game called The Health Behind Connection. I promise I haven't pre-selected a question. We're going to just pick one and pose it to you. And also this is a surprise to you as well, because we realized midway that we should probably try this. So our question is, oh wow. What's a project, experience, or class that made you feel connected to a bigger purpose?
I would say that the entire residency experience of really 5 years, surgical residencies are anywhere from 5 to 7 years, depending on the specialty, and then fellowship is usually a couple years after that. But the residency experience in particular, because you're with the same people, it's very tight-knit, and you're under this really high-pressure environment where you're, working with all kinds of people, remember, and I think you mentioned this when we were talking at the beginning of the podcast, Sanjana and Gabby, you may have never met if not for this thing. In college, even though there's all kinds of people, we tend to segregate most with the people who are most like us. And so we tend not to always we just tend not to go out and just meet random people who are nothing like us. When you get to residency, like any job, now you're suddenly surrounded by people who are nothing like you. But unlike your first job in the working world, in residency, the limit is 80 hours a week, and we're better about that, but still you're working oftentimes in excess of that, at least informally. And when I was a resident, it was easily 100 hours a week at the hospital with these people. And so, you're working with people that are totally different than you. And then you're working with patients who are all very different than you for the most part. And so it's really eye-opening. It takes you from being just a young person with a lot of kind of almost, we all have our opinions when we're young. Some of us are more preset than others, but we do think we know a lot, and we have the arrogance of youth, which is wonderful. But it really humbles you very quickly about how the world works and getting rid of your preconceived notions. And that was, to me, still the formative experience of my life. And more than, I love all my friends from high school. I love all my friends from college. I love my friends from summer camp. They're some of the closest people I know. But those people I did residency with, I will always have a shared bond with them, even if we're not always the closest of friends just on that experience alone.
Wow. Seriously, a round of applause. This has been, and I'll say it, and I promise I'm not being biased, my favorite interview so far. When we first imagined this episode, we thought it would be geared mainly towards our pre-med students, but what's become so clear to me throughout this conversation is that this is a must watch for every single person in our club. No matter what corner of the business of health you're interested in, there's so much to take away from this episode. I personally come into this work through the interest in the wellness economy on the business side and then the niche of wellness real estate. And there were several moments throughout this conversation that I stopped to write things down because they were so applicable. Whether it's about innovation, asking yourself, what am I doing now? How can I make it better? How do I adapt as the world changes and continue to serve my customers, in this case, your patients? Not expecting to feel like you're changing the world every single day, but staying focused, staying grounded, and staying close to your mission. That I will never forget that quote. The years will go on. You might as well spend it doing something you like. There were so many insights like that throughout this conversation. After today, I am truly so impressed by everything you've accomplished and the depth of knowledge and perspective you bring. Thank you so much for sharing your time with us today. Thank you for the care and intention you brought to this conversation. Business Behind Health at Duke thanks you, Commerce of Care thanks you, and I, myself, Sanjana, and Jeffrey are incredibly grateful. Thank you so much, Josh.
Thank you guys. And I'm going to share that quote, that little quote with my mom. That was like, you're going to make me blush. Thank you so much.